Okay. So similar but different between postpartum and pregnancy. One of them would be the infection in the uterus. Okay. So what's the infection that's most common in the uterus while she's still pregnant? Anybody know?
Uh, it's not chlamydia, right?
Mm-mm.
Does it start with an S?
Mm-mm.
Did the one that starts with the E, like endo or no?
So the endometritis is going to be the infection in the uterus after she's delivered. That's our postpartum, our most common postpartum infection is endometritis, or the infection of the endometrium, or the lining of the uterus. And it usually originates where the placenta was attached. Infection during pregnancy in the uterus is the chorioamnionitis. And so that is, if you guys remember, I don't know if you remember or not, that the membranes that surround the baby are the chorion and the amnion. Okay, and that's also what tears when the water breaks, but that's where that infection originates. So, if she's pregnant and she has signs of infection in her uterus, the symptoms are often similar, right? So, fever, abdominal pain and tenderness, foul smelling discharge. Okay. If she's pregnant, it could be foul smelling amniotic fluid, maybe purulent amniotic fluid. That's chorioamnionitis. If she's delivered, still fever, abdominal pain and tenderness, foul smelling discharge, but now it's probably foul smelling lochia, right? Then that's endometritis. So similar symptoms, similar location, different name, depending on whether she's pregnant or not. Okay. Um, what else is there similarities between the two? Trying to think. I think that's the one that sticks in my mind as something that they could be, depending on if she's pregnant or not pregnant, that it could have a different name but have similar symptoms. Maybe we'll come across something else while we're reviewing and I'll go, oh yeah, that too. Anything else you guys can think of? Anything you have questions about before we get started? All right, cool. Well, then let me pull up the game we're going to play. So for this game, you can either scan the QR code over here. I can also send you in the chat a link to the game. If you click on the link, you can link to it and see it on your computer, but you'll still be on Zoom, but you won't see me on Zoom. But I can still see you. Or you can go to play.bluekit.com and then enter in the code here. Was that everybody? I don't remember if we had 4 or 5. I think it's just us. Okay. Ready? 39-week client reports that her water broke 12 hours ago. Her temperature is 100.8, heart rate's 110, fetal heart rate's 175 beats per minute. What is the primary concern? Okay, so the answer is chorioamnionitis. All right. Now that we know that's the answer, which of the things in the question helps point to that being the diagnosis?
Would it be her
The
fever,
temperature.
The
Oh,
fever. What else?
her heart rate?
Her heart rate. Remember, so we actually were just talking about this, right? The chorioamnionitis is the infection in the uterus while she's still pregnant, okay, usually in labor. And so we're going to see fever, we're going to see increased heart rate. If she's still pregnant and she has an infection, the baby's also going to have an increased heart rate. Okay, so a big thing we see with chorioamnionitis is both maternal and fetal tachycardia. And then often that baby's still tachycardic at delivery, has that elevated heart rate. Okay. And so for this one, the heart rate of being 175, what's the normal high-end heart rate for a fetus?
110 to 160.
Good. So the fact that she's got fever and she's tachycardic and the baby's tachycardic are all really clear signs. Other things we might see besides the fever, and I just mentioned it before we started the game, what other symptoms besides fever and maternal and fetal tachycardia might we see with chorioamnionitis?
The smelly,
The smells?
The smells. So the amniotic fluid could have a foul
that's what it
smell.
is.
Yep. Also uterine tenderness if the infection's in her uterus. Okay, good. All the smells. A client is receiving oxytocin to augment her labor. Which assessment findings should cause the nurse to immediately discontinue the oxytocin infusion? Late decelerations. Why are we concerned about late decelerations?
Because that means placental insufficiency.
Yeah. Okay. And so do you guys remember the things that can cause placental insufficiency?
It's not cord compression or head compression, right?
Right. Cord compression causes what kind of decelerations?
Variable?
And then head compression causes what kind of decelerations?
early.
Early. And that's why the yellow wasn't a choice that we needed to select because head compression's normal, right? If we saw early decelerations, what would we need to do?
Reposition the mother.
Not even. Not
Oh,
for now for variables we could reposition the mother because that could help relieve pressure on the cord. But for early, we're just getting pressure on the head coming through the birth canal. What do we need to do about that?
Monitor.
Yep, nothing to do. So anything for early, anything that you see that says this is normal, so continue to monitor, document the finding, reassure the parents. There's nothing to do for that. For this one though, for late decelerations, the things that can cause late decelerations or cause a decrease in placental perfusion are going to be, there's a lot of things that could cause it, but a lot of the big things we think about are going to be her blood pressure. Okay, remember if her blood pressure is low, she's not perfusing her placenta well. Her contractions, if they're too strong or too frequent or too close together, we're not getting a good fill time where that good oxygenated blood can come into the placenta when the placenta is or the uterus is relaxed. Because that when the uterus is squeezing, it's compressing the vessels that feed the placenta. And so if this patient's on oxytocin, Okay. And so if it says which would cause the nurse to immediately discontinue the oxytocin, the late decels, because our contractions are potentially causing our placental perfusion issue. Okay. What do we do with late decelerations? What's our interventions for that?
That's your
C-section.
stopping it, no tocolytics, oxygen. Um,
And Daniel, what did you say?
Just prepared for like a C-section.
Yeah. The first thing to do also is still reposition because the repositioning is very fast, easy, non-invasive, and that might help perfuse our placenta better. For this patient that's on oxytocin, we should turn it off, which is what we talked about. But also, yes, notifying provider, being prepared to deliver via C-section if needed. Oxygen we can do. But if we're giving her oxygen and we're not getting the oxygen through the placenta, that by itself isn't really our big fix. We can also give a fluid bolus if her blood pressure is low. But for this question, turning off the oxytocin is the best choice. The nurse knows to frequently assess the following to identify magnesium toxicity. Okay. Why are we giving magnesium?
For if they have like a seizure, maybe like the eclampsia.
So to prevent that, right? To prevent the seizure or to prevent her from moving from preeclampsia to eclampsia, right? So preventing the seizure is the point. The magnesium is going to be a CNS depressant. So it's going to take a lot of the things that are excitable in her body, the way that it's affecting her neurologic status and all these things, and kind of simmer that down. So watching deep tendon reflexes is important. Okay, what would be a sign of toxicity with deep tendon reflexes? Like at what point, if you were assessing deep tendon reflexes, would you go, that's concerning that we're developing magnesium toxicity? Anybody know this?
Like like plus like two or three, I'm gonna guess.
So a good guess. If she's preeclamptic, oftentimes we can see those deep tendon reflexes being really brisk, like +3. And so magnesium sulfate will probably bring that down, okay, to try to stabilize her neurologic status better. So, because if we're really hyper reflexive, that could be a sign that she is having a lot of neurologic involvement, and it could be a sign that she is going to have a seizure or be at risk for having a seizure. So deep tendon reflexes that are brisk, like 3 plus, and then they come down to 2 plus or even 1 plus is probably a good thing. But the thing that would be a sign of toxicity would be if they are absent. If we've gone from this excitability to nothing, if I can't elicit a deep tendon reflex response, that could be a sign of toxicity. That'd be concerning. Okay. So for respiratory status, what kind of respiratory status change might we see with magnesium toxicity?
Like it'll go below 12, like respiration.
So yeah, so
paper.
it'd be so for toxicity, it'll be low and slow. So if the respiratory rate is below 12, then that could be a sign of magnesium toxicity. And depending on the severity is going to depend on what we should do about it. So respirations are one of the things we really are monitoring closely, and then potentially treating for toxicity if the respiration rate is low. Okay. What about level of consciousness? With toxicity, what might we see with level of consciousness?
I think like
Lethargic.
more lethargic.
Mm-hmm. Okay. What about urinary output?
Less.
Less than what?
30 mLs per hour.
Good. Less than 30 mLs per hour. Excuse me. And the thing that's concerning with that is that her body also metabolizes the magnesium through the kidneys. And so if her urine output is less than 30, she's also hanging on to more magnesium, which is going to potentiate the toxicity and make it worse. Okay, so all of these things in the blue section, if we have absent deep tendon reflexes, if we have low respiratory rate, if we have altered level of consciousness, like lethargy, or if we have low urinary output, all of those things would be concerning for magnesium toxicity. If I'm concerned about magnesium toxicity, what should I do?
Stop it and use the calcium gluconate.
Yep. Okay, so first turn it off. All right. And then calcium gluconate is our antidote. Calcium gluconate is going to, if you think about fluid and electrolytes, calcium and magnesium compete. So calcium is going to push the magnesium off the cell receptors, which then now is going to put us back at risk of having a seizure, but it's a trade-off. So typically in the hospital, they have a parameter for give calcium gluconate for rest. I think the hospital I work at, I think the parameter says give calcium gluconate for a respiratory rate less than 6. So if I have a parameter to give, then I would follow that, but also be in close contact with the provider. But if I don't necessarily hit my parameter for giving calcium gluconate, but I'm still concerned my urinary output is less than 30, my deep tendon reflexes are absent or whatever, then I will also be having those conversations with the provider to see what they want to do. If they want to give calcium gluconate. Okay. Which statement would alert the nurse to worsening of gestational hypertension? Okay. My vision for the past 2 days has been really blurry. Um, so with just what's happening with gestational hypertension, first of all?
Blood pressure is high,
The blood pressure is greater than, do you guys know the parameter?
140,
Greater than 140 systolic or greater than what systolic?
150,
90.
Mm-hmm.
90.
So greater than 140 systolic or greater than 90 diastolic. And it is going to be for gestational hypertension, it it has developed after 20 weeks of pregnancy. So she wasn't hypertensive before, but after 20 weeks, she's developed this elevated blood pressure 2 times or more with more than a 4-hour difference between them. Okay. So we know she's gestational hypertension, but in order to, some patients can have gestational hypertension and not be preeclamptic. So once they have developed gestational hypertension, we're watching them closely for preeclampsia. And the signs that could indicate preeclampsia, one of them is those visual changes. It's not really being able to focus. This one, or saying that their vision is blurry, having variations in their vision, things like that can be a sign of that neurologic involvement that can happen. What other things might we see that would indicate that our patient has developed preeclampsia besides visual changes?
Like a headache that doesn't like go away.
Yep, that constant headache, it's not being relieved with treatment.
Protein in the urine.
Protein.
Edema.
Protein in the urine is a big one. For edema, it is normal to have some swelling in pregnancy, which is why that blue option wasn't the right answer. The swelling in my hands and feet has gone down. It's normal to have some edema but if it's sudden onset, if it is not dependent edema, so when pregnant women that are on their feet all day tend to have swollen ankles, and that's normal. But if it's like hands and face is a good sign that that edema isn't normal. So some edema, it just depends on what she's got and how much, when it started, like those things can be a sign. But definitely proteinuria is a big one. Visual disturbances, headaches, also sometimes epigastric pain, because that can be a sign of liver involvement as well. So sometimes they'll have epigastric pain, or they might feel right upper quadrant pain. So any of those things could also be signs. The client understands their insulin needs in the second half of pregnancy if they state they may require what? Okay, the insulin needs go up, right? So any pregnant woman, regardless if she's diabetic or not, becomes insulin resistant to some degree during pregnancy because the body wants to hang on to the glucose to grow a baby. So if she's diabetic and needing insulin, as her body progresses through pregnancy, her insulin needs are going to keep going up because her body becomes more and more insulin resistant. Okay. In the first part of pregnancy, the needs are pretty low. In fact, they might even go down. Nausea and vomiting, not eating well, things like that. And then as pregnancy progresses, it goes up. After pregnancy, after she delivers, the needs go back down to normal, or even a little bit less than normal with breastfeeding. Okay. If our patient's diabetic, what kind of things should we teach?
Monitor their sugar.
Eat every like 3 to 4 hours.
Mm-hmm.
Try to exercise.
Yeah.
It's like a lot of lifestyle type changes, and then obviously some medications if need be.
Good. Yeah, so exercising is going to help maintain the blood sugar. Everything like with them are going to be related to glycemic control, right? So everything you guys said is very appropriate. And checking those blood sugars are going to be really important to make sure that they are maintaining kind of a pretty stable glucose level. If they have big variations in their glucose levels, that can be something that can cause a baby to be macrosomic. And so glycemic control is important before she gets pregnant also. If she is a pre-gestational diabetic, if she has diabetes before she gets pregnant, because the poor glycemic control can cause birth defects and things. Okay. But if she develops gestational diabetes, that's a patient that wasn't diabetic before she got pregnant. She develops diabetes after 20 weeks. 20 weeks is like our magic number for gestational conditions. Okay. Her baby won't be at risk of having birth defect issues from poor glycemic control, but her baby still has other risks. What kind of risks happen with diabetic babies are born to diabetic moms?
Respiratory distress syndrome,
Mm-hmm.
right?
Yeah.
And they're big.
They're big.
Mm-hmm.
For macrosomia.
There you go.
Lorena, you did make it. You guys can join the game. Do you want me to send a link again? So macrosomia. Okay, so big babies. And if the baby's big, what kind of considerations might we have for that? We might need to do a C-section. The baby might not be like the concern is if the baby is very large would be whether or not the baby could get stuck like a shoulder dystocia. And so oftentimes if the baby's large, they'll recommend a C-section. Okay. So C-section risk increases. Baby could have respiratory distress syndrome. What else could happen with baby if mom has poor glycemic control?
A miscarriage or stillbirth.
That is true. If she has poor glycemic control at the beginning of pregnancy, she was diabetic before she got pregnant, increased risk of stillbirth for sure, or miscarriage. Yep. Baby also then has a high risk of hypoglycemia after they're born. And birth injuries, if we do deliver vaginally and we have a shoulder dystocia, we could have like a clavicle fracture or brachial plexus injury. So there's a lot of things that can happen if that baby's really large. Okay. Lorena and Brandy, did you get into the game?
No, I'm actually driving right now. Sorry.
Okay. The other thing, guys, I thought of after we clicked off of the preeclampsia question in relation to swelling. We were talking about swelling and how that might be a symptom of preeclampsia, but it is true with preeclampsia that the cells become leaky, which is what causes that edema that we can see. And so if we have a patient that's preeclamptic, seeing that swelling go down after the baby's born can be a sign that her preeclampsia is improving. So that we do look at edema, as far as like what we might see during and then also what we might see after. Anything else about diabetes? I don't remember if there's any other diabetes questions in this game. Trying to think. Well, if we have any other questions about diabetes, we can still talk about them. All right. A nurse is caring for a client who has placenta previa. Which of the following findings should the nurse expect? Okay, so this one is painless bleeding. What is happening with a placenta previa?
I think it like covers like the cervix, like the cervical os.
Good. Yep. It's going to be at the bottom of the uterus and it's covering the cervix. So the cervix in a non-laboring woman's like a tube. It's kind of thick. You have the external os of the cervix that opens down into the vagina. You have the internal os of the cervix that's inside, is at the base of the uterus. So with this, the placenta is covering that internal opening of the cervix. Okay. And so if we have bleeding from this, it is caused by just kind of changes that happen in the cervix through pregnancy, and it's not a painful thing for her. She just all of a sudden is noticing she's bleeding. Okay, because it's covering the cervix. What kind of delivery needs to happen for a patient with a placenta previa?
C-section.
But whether or not we do a C-section, like when we determine when to do the C-section is going to be dependent on how she's doing. If she isn't having significant bleeding, we're going to keep her pregnant as long as possible and try to get that baby as close to term as we can. If she's having significant bleeding early, then we might have to deliver sooner. But just because she comes in bleeding doesn't mean we automatically have to do a C-section right then. It depends on presentation. It depends on how the baby is, how mom is, like what her vital signs are, how much she's bleeding, and if the bleeding resolves. If she's hosing blood, we have to deliver. But if it is like a bleed that stops, oftentimes we'll monitor her. And if she has 5 days without bleeding, we can potentially let her go home until we get closer. How can we diagnose a previa? If she just came in with painless bright red bleeding, how can I know that it's a placenta previa?
Would you do like a scan to see?
Wouldn't you
Mhm.
run like labs for blood? Or
Well,
is
if we
that not
run
like
lab work, that might tell us if she's losing volume, but it's not going to really tell us where the placenta is. So Gladys is a scan. So really an ultrasound. If we put an
Yes.
ultrasound on her, we can look and see where's the placenta. Okay. So ultrasound can diagnose it, like, because it can tell us where the placenta is. And we should not check her cervix, and we shouldn't teach her also not to have anything in her vagina. Okay? Because we don't want to accidentally disrupt the placenta at all, because that thing will bleed like crazy, potentially. Okay? So this one, the yellow, somebody picked yellow, characterized by detachment of the placenta from the uterus. What is that describing?
Placental abruption.
Placental abruption. And what might we see with a placental abruption? How is it different from a previa?
Lots of pain.
It's painful,
Dark red
dark?
bleeding.
dark red bleeding. Yep. What happens that can precipitate a placental abruption?
Trauma.
Trauma. So trauma could be car accident. It could be I fell down the stairs. It could be my toddler kicked me in the belly while we were playing. It could be intimate partner violence. A lot of different things could disrupt the placenta in that way. Cocaine use can also cause it. Sometimes hypertension. Because if you think about, we've talked about how blood pressure affects how we perfuse the placenta in relation to like low blood pressure. But if we have high blood pressure, it's like got a lot of pressure coming into the uterus, and so it can cause the placenta to separate as well. Okay, but if we have painless and bright red bleeding, previa. Painful dark red bleeding, abruption. A nurse is admitting a client of 42 weeks for an induction of labor. What is a predictor the induction will be successful? Okay, let's talk about this one. All right. So this is a week 6 concept, and you guys haven't really done this in class yet. Okay. When we look at inducing labor, one of the things we're going to do is we're going to check our cervix and see kind of where we're starting from. Okay, how open is it? How soft is it? How effaced is it? Or thin? And we score it depending on, let me see if I have a picture of what I'm trying to talk about here. I'm going to show you guys the bishop score real quick. Okay. That's kind of blurry because I zoomed in, but we're going to look at this for a second. So we look at the cervix. We look at the position of the cervix in relation, like when they check it, is it really far back? Is it in the middle or is it towards the front? Consistency, is it soft? Is it firm? Effacement, how thin is it? Dilation, how open is it? And then we also look at that fetal station. I don't know if you guys remember the fetal station from week 3, and that's where the baby is in relation to the pelvis. And all of these get points, okay? The lower points, this is called the bishop score. Low points means the cervix isn't really favorable. And if a cervix isn't favorable for labor, that just means that her body's not really ready to be in labor yet. Our chances of success of getting her delivered is low. So what we want to do with a score that's low is to do what's called cervical ripening to make the cervix more favorable. Does anybody have any idea what we might use to make a cervix more favorable?
Could you use like one of those dilator, like one of those instruments. What?
So we could do some things that help dilate the cervix. One of the things that in that way we could do what's called a cervical ripening balloon, which goes inside the cervix and we blow the balloon up. And as the balloon works its way through the cervix, it dilates it. But the cervical ripening balloon, even though it's a mechanical dilator, it also causes the body to release its own something, which is also something we can give. And it is, I wonder if it's on this slide, cervical ripening, it's going to be prostaglandins. This is a peek into the slide that I'm going to use in class this week for those of you that are in my class. So if we have a low Bishop score, cervical ripening is going to be a good idea, and we ripen the cervix with prostaglandins. But for a cervical ripening balloon, that also causes her to release her own prostaglandins, which also helps soften the cervix. So when we think about cervical ripening, if the Bishop score is low, that's going to be like our prostaglandins. In the game, it says what is a predictor that the induction will be successful. Bishop score is 10. If we have a high Bishop score, her cervix is very favorable. And so she doesn't need like prostaglandins. She probably just needs maybe some oxytocin to make her uterus contract. They might break her water, things like that. Okay, so the Bishop score gives us an idea of inducibility. Does that make sense? Keep game active. Okay. Chronic hypertension is defined as hypertension prior to what? Okay, prior to 20 weeks. So we talked about gestational hypertension with the question that was related to preeclampsia. A patient that has chronic hypertension means we have those elevated blood pressure prior to 20 weeks gestation. This patient also could still develop preeclampsia. So we're still watching for the protein in the urine and things like that. The nurse should recognize that emergence of the fetal head followed by retraction against the perineum is called what? Okay. This also is something that is more from week 6. So this is considered, if we see a turtle sign where the head retracts against the perineum, what might be happening?
Does that
Shoulders
mean like it's coming
extension.
back in?
So what happens with the turtle sign is the head, we have momentum as the head's coming out and then it kind of pulls back. And that's called a turtle sign, and it is a sign of a shoulder dystocia. So with a shoulder dystocia, the shoulder's not coming underneath the pubic bone. So we have the baby delivering and the head comes out and then the shoulder gets stuck on the pubic bone. And so then we lose our momentum and the head pulls back. Okay. What do you guys think? Is this an emergency?
Yes.
Definitely. Okay. Definitely this is an emergency. We have the head out and we have the shoulder stuck in the perineum, or I mean on the pubic symphysis. And then we're not getting good blood flow through the cord to the baby because the rest of the baby's body is in the vagina because it's about to be born. And so potential for a huge decrease in oxygenation to the baby. So we really need to get the baby to finish delivering. Does anybody know what we might do to try to resolve a shoulder dystocia?
It's something where you put them in the position and put pressure right above the subpubical area to have the shoulders compressed together slightly.
Let me see if I can show you.
Could you position the mom differently?
Yes. Okay, I was trying to see if I can find a picture. So one of the things would be, so this is our shoulder dystocia, the head's out and the shoulder's stuck. Things to do are going to be, we can change mom's position as a choice, right? So we could do position change, but first thing we'll probably do is call McRoberts. McRoberts says to hyperflex the legs. And so it's like kind of putting her legs on her abdomen or sending her knees towards her ears, where we're going to push, and it's going to shift the pelvis to try to raise that pubic bone up. The other thing that could be done here is called suprapubic pressure, where they're putting pressure above the pubis to try to force that anterior shoulder underneath the pubic bone. Okay. In order to do these maneuvers, it's going to be helpful to have more help. So if I have turtle sign, the head comes out, shoulder doesn't release, I'm watching the baby. As the nurse, I'm usually like supporting the leg. I'm watching the baby and I'm watching the provider, and I'm waiting for them to tell me what they feel, because they will feel that get stuck. And as soon as they tell me it's a shoulder dystocia, immediately we're doing McRoberts first. So we're hyperflexing the legs. Then we're going to depend, it's going to depend on what he or she wants next. Okay. As far as suprapubic pressure, changing positions, things like that. So I'm going to call for help and be prepared to do my other maneuvers.
Are these maneuvers chosen by the physician or by the patient?
By the physician.
Okay.
They're the ones that feel what's happening. So this is one of those emergency situations where they're going to tell us what they need to do, but we know what needs to happen kind of in a fairly systemic order. So the first thing always is McRoberts. And sometimes if I don't see the head, I see the head stop and I don't see that anterior shoulder release, I'm already starting to flex the legs before the provider. I say she because most of my providers right now are female, but before they even tell me this is a shoulder dystocia, if I don't see that anterior shoulder releasing, I see turtle sign happening just from my point of view, I usually start flexing the legs right away or doing McRobert. And then they'll be able to speak to, this is a shoulder dystocia. I would like suprapubic pressure. Suprapubic pressure is usually the second thing to try. So we do McRoberts, then we do suprapubic pressure typically. And then a lot of the other maneuvers are done by the provider, and then they're telling us what they need. Okay. But that's why calling for help is a good idea, and then being prepared to help with the maneuvers to release the shoulder. Okay. Okay, so let's go back to our game. All right, so turtle sign is a good sign that we have a shoulder dystocia. An obese client with pregestational diabetes has a fetus that is macrosomic per ultrasound. The nurse is aware that what? Okay, increased risk of shoulder dystocia with a macrosomic baby. All right. This is why oftentimes if the baby's macrosomic, they might recommend a cesarean birth if the baby's measuring over 4,000 grams, which is 8 pounds, 10 ounces, I think. I'd have to calculate. I think that's right. So if we think this baby is like 9 or 10 pounds, they might say, you know, I think it'd be safer to do a C-section in order to prevent the possibility of having a shoulder dystocia. Because if we have a shoulder dystocia and all the things we just discussed that go with that, if I'm putting pressure here, we can break a bone, right? A clavicle fracture or a humerus fracture is possible with suprapubic pressure. Also, if the provider is really putting a lot of traction on the head to try to get that anterior shoulder to release, that can stretch the brachial plexus of the baby and cause a brachial plexus injury. So that's a concern as well. So birth injuries are going to be concerning. And so that is going to be something that they're thinking about for a patient that has a macrosomic baby, is whether or not we should just do a C-section and prevent that risk. What is the primary goal of treating gestational diabetes? Okay, so the answer is not blue. Why, now that you're looking at it, does anybody know why that wasn't the best answer? Why is preventing congenital malformations and preventing spontaneous abortion not a primary goal related to gestational diabetes?
Is it
Anybody?
because like when you have like I believe like when you have gestational diabetes, like you don't have like the same risk as like those that have chronic diabetes. Like it doesn't like it would only apply to you if you had it like before pregnancy, or I don't know if it still applies like with gestational diabetes.
So that's true. Okay, that these things here, the red choice and the green choice, are not going to apply to a gestational diabetic. And the reason for this is because when does a spontaneous abortion happen? Before how many weeks?
20. 20 weeks.
Before 20 weeks. And when do we see congenital malformations happening?
Before the 20 weeks as well.
Yeah, at the beginning. A gestational diabetic is not diabetic until after 20 weeks. And so these conditions will only happen for a patient who has poor glycemic control at the beginning of pregnancy or before 20 weeks. And so that's why these two didn't apply to our gestational diabetic, but we still have the increased rate of fetal macrosomia. Does that make sense?
Yes, ma'am.
Okay, so these are still concerns for our diabetic patient if she was a pre-gestational diabetic and has poor glycemic control. For the student that it says iPhone, can I put your name in so that I can let your your instructor know you came? I can type it in for you. What's your name?
Professor McBride, it's Brandy. My computer keeps kicking me out.
Oh, okay. It's McPeak.
Yes, ma'am.
Okay. Awesome. I just put it on there so that because I do send out our attendance log and I let all the other instructors know who came. All right, so moving on. 38-week G2P1 client has a blood pressure of 172/114, proteinuria, headache, and difficulty focusing. What complication would the nurse work to prevent? Okay, yep. This patient is at risk of having a seizure. Okay, all of those things that it says, what diagnosis do you think that patient has currently?
Preeclampsia.
She has preeclampsia, right? She has hypertension, proteinuria, headache, difficulty focusing. All of those are signs of preeclampsia. What medication would you anticipate for her to prevent her from having the seizure or prevent eclampsia?
Magnesium.
Magnesium sulfate. A client has an incompetent cervix at 20 weeks gestation. Which intervention will be ordered to prevent preterm birth? Okay. So cerclage, what does the cerclage do?
It basically closes up your cervix so the baby won't come out.
Yeah. So for this patient, it says she has an incompetent cervix. So that's also known as cervical insufficiency. It's a cervix that's not staying closed. It's starting to dilate and efface at 20 weeks or however many weeks. This patient's 20 weeks. It's starting to open before it should. Okay, so the other medication choices or the other choices listed here are all things that we might do if she was at risk of having the preterm birth. But in order to try to prevent the preterm birth, the cerclage placement is really the only thing that's going to help. The other things, the blue and the red, the tocolytic therapy and magnesium sulfate. Magnesium sulfate is also a tocolytic. Tocolytics are medications that will decrease the contractility of the uterus, which are going to be great choices for preterm labor. With this patient, we're trying to prevent preterm birth. It's her cervix is opening. It's not a labor issue. It's a cervical issue. Does that make sense? So giving her medicines to relax her uterus isn't really going to make a difference, but we need to try to keep the cervix from opening more, the cerclage. Okay. Now, if she was in preterm labor, all of these other choices are on the table. Betamethasone is a good idea to help with lung maturity, tocolytics to make the uterus relax. Magnesium sulfate also has another purpose besides acting as a tocolytic. It also can provide neuroprotection for a baby that's going to be born before 32 weeks to help protect their brain. So all of those would be good choices for preterm labor. But for this patient with an incompetent cervix, the cerclage is better. A nurse is administering prescribed medications prior to a cesarean delivery. Which should the nurse administer? Okay, so red is the best choice here. If she's going to have a C-section, we're going to give a prophylactic antibiotic. Okay. We also typically give antacids because if she's laying on her back for the C-section with just a little tilt, a little hip tilt, there's an increased risk that she's going to vomit. And if she aspirates that, and it can be really caustic to her lungs. And so we use antacids to try to minimize the acidity of her stomach contents. Okay. For painkillers and sedatives, we don't typically sedate a patient that's having a C-section. Okay, we can do pain management. So they'll either have a spinal or their epidural is dosed higher or they have general anesthesia. But the things we're thinking about is antibiotics and antacids. A nurse is reviewing the fetal monitoring tracing of a client with ruptured membranes, which might indicate a cord prolapse. Okay, good. So what's happening with a cord prolapse?
There's pressure on that cord, I think.
There would
Is
be
that one?
significant pressure on the cord. But what's happening with a cord prolapse?
It's not that it's like wrapped around, is it?
It's not wrapped. Let me see if I have a picture in here. Here we go.
It's falling down out of the uterus into the vagina.
Yep, good. So the cord has come down in front of the baby's head and into the vagina with a cord prolapse. The cord has come down in front of the presenting part. This is going to cause significant pressure on the cord because the head is going to come down on the cord and put pressure on it. And so that's why we can see really big variable decelerations because variables are cord compression. So we could also, if the head comes down and keeps constant pressure on the cord, we can see a bradycardia. We can see the heart rate drop and stay down. But if the head isn't so well applied to it that during the contraction there's pressure and in between contractions there's less, then we might see the big deep variables. This is most often seen right when the water breaks. Because when the water breaks, you get like that gush. And if the head's not low enough in the pelvis when that happens, the gush can just carry the cord down with it. So if the water breaks and then immediately we start seeing big variable decelerations or we see the heart rate drop into a bradycardia, that's probably a cord prolapse. Okay. If we have a cord prolapse, what should we do?
You have to wrap the cord with sterile gauze and a towel and hold it inside the vagina in place. Stay with your patient.
So we can definitely wrap it in a saline soaked sterile towel to try to keep it moist. We don't want to put it back in the vagina. If we put it back in the vagina, it can cause, if we really palpate it at all, it can cause vasospasms that are going to decrease perfusion, whatever can get through that cord to the baby. But we can wrap it, and that is something that's on the list of things to do. I'm going to tell you honestly that most of the time, if I find a cord prolapse, that's really low on the list because that we're already in the hospital and we're going to be needing to go straight to the operating room. And so other things, what else would we need to do you think?
Reposition.
What kind of position do you think would help for this?
I think knee,
Knee
head
chair.
and knee.
So we call it the knee chest position.
chest.
And the thing with the knee chest position, guys, I don't want you to think about it as the same as McRoberts, because when we talked about McRoberts for the shoulder dystocia, and I told you we're kind of putting her knees this way, with McRoberts, the knees kind of also go to the chest, but it's not the knee chest position. I want to see if I can find a picture of the knee chest position. The knee chest position is going to be with the knees on the bed and also her chest on the bed. So her bottom's up in the air, and that's going to let gravity rock that baby back to help take pressure off the cord until such time as we can very immediately go for a cesarean delivery. Let me see if I can find a picture of this. Cord. Research cord prolapse. Yep, here we go. So let me show you this real quick. So we want to reposition the mother in a way that lets gravity help take the pressure off the cord. So the knee chest position is this top right corner. See how her chest is on the bed and her knees are on the bed? And then that lets gravity rock the baby back. Okay. We can also do a sideline position. This is a modified Sims position where she's almost laying on her stomach. And that can also rock the baby back. There is some places where we see Trendelenburg as a choice. The thing with Trendelenburg, if you see it and that's the best choice, you could pick it because Trendelenburg lowers the head of the bed, which then would rock the baby back. The reason that I don't focus on that position as much is because that if we have her in that position, it can put pressure on the vena cava. So then we're not getting good placental perfusion and we're not getting good blood flow through the cord. So I don't usually pick Trendelenburg as a first choice. Knee chest is going to be the best. Okay. And then typically whoever is the finder is going to be the holder. So you're going to have somebody with 2 fingers in the vagina pushing up on the head, trying to relieve as much pressure off the cord as possible until we can get the baby out. Okay. And then this is emergency C-section. Because we're not gonna, the cord's now in front of the part. So as the head came down to try to deliver, it's gonna put too much pressure on the cord. We won't get good perfusion to the baby. A PPROM client is receiving magnesium sulfate for neuroprotection. The nurse should monitor for which adverse effect? Okay, so in explanation for the first part of the question, PPROM is premature, it's preterm, so she's early, premature rupture of membranes, which means she's preterm and her water broke before labor started. We'll give magnesium sulfate to these mamas because it can decrease the contractility of the uterus to help keep her pregnant a little bit longer, which will give us an opportunity to give betamethasone to help mature the baby's lungs. But also magnesium sulfate provides neuroprotection for the baby. It decreases the risk of brain bleeding. But for this patient on magnesium sulfate, we have the same considerations for her as if we had been giving her magnesium sulfate for preeclampsia. Okay, so all of those things we talked about at the beginning of our game, if you were here, related to signs of toxicity also pertain to her, even though that's not the reason she's getting the medication. Because remember that magnesium sulfate is that CNS depressant. So we're still monitoring for all of those signs of toxicity. So we talked about these before. Respiratory depression is one. What else are we monitoring for related to magnesium toxicity?
Hyperactive tendon.
So hypo, if we have toxicity, we have the absence of deep tendon reflexes. With preeclampsia, we have that hyperactivity. With magnesium sulfate, it can make it go away. So if we have absent deep tendon reflexes, that'd be concerning. Respiratory depression. Decreased urine output, less than how much?
30.
Less than 30 mLs per hour. We also talked about like mental, like lethargy, right? What else? I'm trying to think. Those are like the biggest ones. Yeah, those are the biggest ones. Is like the respiratory depression, the decreased urinary output, and the absent deep tendon reflexes are the biggest ones. Okay. So that's true also then for our patient that is preterm and on magnesium sulfate for her baby's benefit, that we're still monitoring for those signs. So hyporeflexia, not hyper. Okay, absent of deep-tendon reflexes. We could also see the blood pressure go down. Typically, I don't see a patient become hypotensive on magnesium sulfate. It does affect the blood pressure a little bit. So for our preeclamptic patient, it sometimes does help, but that's not going to be like a treatment for high blood pressure, if that makes sense. But if this patient is not even, that's not even why she's getting it. Which medication should the nurse expect to administer to a client who's experiencing preterm labor? Good. All of the other medicines that are listed here, oxytocin, misoprostol, methergin, these are all medicines that do what?
Increase.
Increase the contractility, make the uterus squeeze. So those are all great medicines for postpartum hemorrhage. For a patient that's experiencing preterm labor, we want to relax the uterus. Nifedipine is the only one listed that helps the uterus relax. Do you remember what other medicines help the uterus relax? These are our tocolytics.
The IND one.
Yep. Which is
And
indocin or indomethacin.
yes.
Yep.
And magnesium
Magnesium
and
and terbutaline.
mhm.
Terbutaline is the one that helps the uterus relax that sometimes we'll give as our tocolytic of choice if we're also having concerning fetal heart tracings. So when we talked about the late decelerations and what we should do for that, terbutaline is our tocolytic of choice for that, but we also can use it for preterm labor. So those are our 4 medicines that relax the uterus, okay? A client is diagnosed with preeclampsia. What finding could indicate the client may be developing HELLP syndrome? Okay. Epigastric or right upper quadrant pain. Does everybody understand what HELLP syndrome is?
Not really.
Okay.
I know that it stands for like hemolysis, elevated liver, and low platelets. And
Yeah.
like you can develop it from having eclampsia.
So with HELLP syndrome, it is a variation of preeclampsia. Okay, if she has HELLP syndrome, she's preeclamptic. But you could be preeclamptic and not have HELLP syndrome. But you can't, if you have HELLP syndrome, you are preeclamptic. So some of these symptoms are going to be really similar in that we have the high blood pressure. We can see, so this epigastric pain and the right upper quadrant pain, you can see that with preeclampsia also, but it's more severe with HELLP syndrome. Because with HELLP syndrome, we have a lot more liver involvement. Okay, and so the liver lives over here on that right upper quadrant, and so this pain can be really significant. With HELLP syndrome, that we see a very significant decrease in platelets. So with preeclampsia, you can see the platelets go down, but with HELLP syndrome, they go down more. And they drop significantly and quickly. And so it's a lot more dangerous. Oftentimes, patients with HELLP syndrome need to be delivered pretty quickly. And so oftentimes I see them end up with a C-section because we just don't have time to induce a labor. The platelets are falling too fast. Okay. So HELLP syndrome, correct. Is it Fatima or Fatima?
Fatima.
Fatima. So what she said about the acronym, hemolysis, elevated liver enzymes, low platelets is what it stands for. And it's a variation of preeclampsia that's more severe. Okay. But right upper quadrant pain, epigastric pain is very classic with this because of the liver involvement. The uterine fundus right after delivery of placenta is palpable at good. Yep. So right after delivery, we expect to find it pretty close to the belly button. So at the level of the umbilicus. The nurse observes the client's amniotic fluid and decides that it appears to contain meconium because what? Okay, good. So what's meconium?
It's the fetus poop, I should say.
Yeah, it's the poop. So if they pass their meconium before they're born, then it's going to make the amniotic fluid have a green look to it. This is concerning for the newborn because remember, guys, that the baby breathes in the amniotic fluid. That's normal. But if it has meconium in it, meconium is thick and sticky, and so it can cause problems for the baby's respiratory status. And so we get impaired gas exchange if they aspirate meconium-stained fluid. So we might see respiratory distress for the baby after they're born if there's meconium-stained fluid. Okay. Meconium-stained fluid also can be an indication to us that there's been or is currently having some fetal distress because that's what can cause them to release meconium before they're born. The other thing in this clue, the little white specks, that's just vernix, and that by itself is a normal finding. So like on the blue choice where it says clear, almost colorless and containing little white specks, that would be very normal amniotic fluid. The one that in red where we still have the little white specks, but we have the cloudy and green is the indication that we have meconium. A delivered client has a temp of 101.4. The uterus is tender, unusually large, and not descending. What should the nurse assess next? All right. So what do you think is happening? Our patient has a fever of 101.4. Uterus is tender, unusually large, and not descending. What do you think is happening with our patient?
Is she having a hemorrhage?
So we do have a concern about her bleeding, which we'll talk about in a minute, but there's something else happening with her. Do you guys, those of you that were here at the beginning, do you remember what we talked about that can happen postpartum?
Is it the infection?
So she's got a fever of 101 and a tender uterus. So those are signs of infection. And do you remember we talked about chorioamnionitis is the infection in the uterus while she's pregnant. And then what is the infection in the uterus after she's postpartum?
Is it endometritis?
Correct. So for this patient, we're concerned that she has endometritis. She's got a tender uterus and a fever. The other thing about this, though, guys, and this question, I like it because it has two things to consider. One is the fact that she's got endometritis. The second part is the fact that she has an unusually large, not descending uterus. So she has subinvolution, right? Unusually large and not descending. We have subinvolution and an infection. So does anybody know what can happen if you have subinvolution and an infection in the uterus? It's going to be what Shay said when the first thing she thought we were worried about.
Hemorrhage.
Hemorrhage. So real quick, I want to like take a little field trip into talking about subinvolution hemorrhage for a minute. Okay. If a patient bleeds in the first 24 hours, that is an early hemorrhage, which is usually caused by uterine
Boggy
atony. Yep.
boggy
Uterine atony or boggy uterus, right? If a patient has bleeding after the first 24 hours, that's considered a late hemorrhage. And a late hemorrhage can happen all the way up to 6 weeks out. And most common cause is endometritis or retained placental fragments. So this patient probably has endometritis, but she also has subinvolution. The uterus isn't returning to the pre-pregnant state. I'm worried about her hemorrhaging. So Lokia, let's look at her pad. What are we putting out? Right? And so for this game question, we needed to first identify that she probably has endometritis and then also identify that that increases her risk of bleeding. So that's why we need to check her lochia. Okay. Make sense? Yes, no? Questions?
Yes, makes sense.
Yes, makes sense.
Okay. Which of the following amounts of blood loss following birth marks the criterion for describing postpartum hemorrhage? More than 500 mLs. Okay. So more than 500 mLs is going to be our cutoff. If we have more than 500 out, then we have that postpartum hemorrhage diagnosis. And then we talked already on the other slide about, or on the other game question about our medicines that relax the uterus, our tocolytics. If I have a patient who is having a postpartum hemorrhage, so we just said on the last question, we said uterine atony is our big cause of bleeding in the first 24 hours. If I have more than 500 mLs out, I have uterine atony, what are my medicines to make the uterus contract?
Oxytocin.
Oxytocin.
Cytotec.
Cytotec, which is also misoprostol.
Methadone.
Sargent.
Okay.
And
The other one starts with an H.
Hemabate.
Hemabate.
Yep, good. What is a contraindication with hemabate?
Asthma.
And what's a contraindication for Metrogen?
Hypertension.
Good job, guys. After precipitous delivery, a patient has continuous bright red blood trickling, a firm uterus, and tachycardia. What condition could be the cause? Okay, so if we have a firm uterus, but we're having a constant trickling of blood, that can be a sign that we have an unrepaired laceration. Okay, so the first thing we think when we go to check on our patient, if this patient is tachycardic and has blood on her pad, I'm checking her fundus. It's probably uterine atony, but we checked her fundus and found her uterus is firm. So then if it's not uterine atony, then the next best thing to consider is the vaginal laceration. Okay. So she had a precipitous labor. What does that mean?
Fast labor.
It was fast, like less than 3 hours fast. Okay. With a fast labor, we could definitely have lacerations because the baby comes out really quick. What else could we see with a precipitous labor besides lacerations? She could also get a hematoma. With a hematoma, I could see the tachycardia and the firm fundus, but then I wouldn't see the trickling of blood because the hematoma has the blood going into the tissue instead. So we would see it like on the vulva. Or maybe she's having pain. Hematomas are really painful. If a hematoma is forming on the vulva and it is like intruding into the space that close to her urethra, it might also make it hard for her to pee. But she wouldn't then have the trickling on her pad. So precipitous labor can cause lacerations, hematomas, hemorrhage because the uterus doesn't want to contract well. It's been working hard and fast to get that baby out so quick, and now it's tired and lazy. So we could also see that, but on this patient we checked and the fundus was firm. So the fact that we've got that trickle is a pretty good sign that we have a laceration. If you have a patient who has a laceration, once it's repaired and it's not bleeding anymore, what other considerations might you have for her? Just like now we're thinking postpartum. So she's not bleeding anymore. It was repaired. What other considerations do we have for a patient with a laceration? Do you want her to be constipated?
No, so you give her stool softener.
We could give her stool softener. We could give her the teaching that helps her poo. So what kind of teaching helps her poo?
Eating high fiber food.
What else?
Increase fluids,
Sure.
ambulating.
There you go. See, now we're thinking. All right. If she has a laceration, depending on where it is, so on the game right now, it was in her vagina. We definitely still, there's not a lot of tissue between the vagina and the rectum. So still, I don't want her to be constipated. If she has a laceration that's in the perineum, those are where we do the stages. Like if she has a first degree, second degree, third degree, fourth degree. And those ones definitely we don't want her to be constipated either. And we're doing the increased fluids and fiber and ambulation and all those things. But we also then don't really want to have to use suppositories to help her to go because that tissue, we don't want to disrupt it either. So anything that keeps her stool soft and moving are going to be helpful because we don't want to have to try to help her go to the bathroom. We don't want her to be constipated for sure. And then also, I guess the other thing that I am thinking of too is going to be good perineal care. So the peri bottle, the ice packs, things like that would also be good for a patient with a laceration. An assessment for what complication has the highest priority for a client with severe postpartum hemorrhage. Okay, yep, good. So anything that causes large amounts of bleeding increases our patient's risk of developing DIC. So in OB, postpartum hemorrhage and placental abruptions are our biggest ones. Okay, and so this patient that has a severe postpartum hemorrhage is at risk of developing DIC. What might we see with our patient that is in DIC? Does anybody know? With DIC is called a consumptive coagulopathy. So basically what's happening is that something related to the bleeding has triggered this abruption of the clotting or interruption of the clotting cascade. And so it's causing everything to clot. And when everything's clotting, it's making all these tiny little microclots. It's not clotting things that matter. So every place we need clotting factors for, we don't have it. So everything actually with DIC is bleeding. So even though she's clotting everywhere, she's not clotting in the places that help. So what we would see is things like maybe any place that she could bleed from, she's bleeding from. So like puncture sites, IV sites, blood in her urine. We can see petechiae where we do like the blood pressure because it's breaking capillaries there. Anything is and everything is bleeding with DIC. Okay. Yeah. And then if she was hemorrhaging, what kinds of signs and symptoms for hemorrhage would we see?
Plotting.
So just separate from DIC, if your patient was hemorrhaging, just in
Hypo hypotension,
hypotension.
increased respiration.
Yep.
Tachycardia.
Tachycardia. Tachycardia is the first vital sign change we usually see
Okay.
even before the blood pressure starts dropping. Usually blood pressure dropping is a later sign. So tachycardia, hypotension, increased respirations, what else?
Pallor.
Yeah. Maybe confusion. She's not perfusing her kidneys well, so maybe oliguria or decreased urine output. Okay. The nurse is documenting assessment findings on a client 14 days postpartum, which indicates a normal involution process. Good. How much does the uterus go down per day with normal involution?
2.
1 to 2.
Yeah, 1 to 2.
Yeah.
Is it centimeters?
Centimeters. Yeah. And so in the postpartum period, guys, we typically measure it with our finger and the width of one finger. So we might say a finger breadth or the width of your finger but it's about 1 centimeter. So 1 to 2 centimeters per day. So by 14 days, we shouldn't be able to palpate it. If we are able to palpate it, then we have subinvolution. And then we got to kind of figure out why do we have subinvolution? Because the main reasons for subinvolution is going to be that infection we talked about or retained fragments from the placenta can cause it. So then we also, again, would be checking the locus to see what our bleeding looks like. But this patient, we shouldn't be able to palpate her fundus 2 weeks out. Fetal heart rate is checked following rupture of the bag of water in order to what? Okay, so this brings us back to the question related to cord prolapse. So remember when I showed you the picture of the cord that's down in front of the presenting part, and we said that the most common time for this to happen is when the water breaks, because the water can take that cord and bring it right down into the vagina below the presenting part. And so right after the water breaks, we really need to check the fetal heart tracing and look for what might we see on our tracing if we have a cord prolapse.
Bradycardia.
Perhaps a bradycardia. What else? Which type of deceleration do we normally see with cord compression?
Variable decelerations.
Good. Okay, so we're going to look for variable decelerations or bradycardia as an indication of possible cord prolapse. All right. And that's why we do that right after water breaks, because that's the most common time for a cord prolapse to happen. A new mother has saturated 2 pads in 30 minutes and has a boggy uterus. Which action should the nurse implement first? Good. Massage the fundus first. What else could we do after we massage her fundus? What else would we consider? There's 3 big things to consider with a boggy uterus. The first one is fundal massage. There's 2 other things that are top on the list after we start massaging the fundus.
Bladder distension.
Okay, so we got to manage the bladder. And then there's one other thing. Medication, uterotonics, medicines that make the uterus squeeze. Okay, so think about the 3 M's: massage, manage the bladder, and medication are big 3 things to do, but fundal massage is first. A 37-week gestation is admitted with vaginal bleeding following the use of cocaine an hour ago. What is the probable cause? Okay, placental abruption. All right, so we talked about earlier in the game some of the things that can cause a placental abruption. And it was, do you remember what it was?
Trauma.
Trauma,
Cocaine
Trauma
use.
and cocaine use. There you go.
cocaine use, sometimes high blood pressure can do it. Okay. But this patient was cocaine was what did it. Uh-oh. Okay, a nurse in labor and delivery is providing care for a client who's in preterm labor at 32 weeks gestation. Which of the following medications should the nurse anticipate the provider will prescribe to hasten lung maturity? Good. So these other choices, indomethacin is going to be a tocolytic to relax the uterus, and procardia or nifedipine is a tocolytic to relax the uterus. Calcium gluconate is our antidote for what?
Magnesium.
Magnesium.
Magnesium sulfate, which we don't have any indication that she's on magnesium sulfate, but the thing that's going to help with lung maturity is the betamethasone. We give the betamethasone to the mom, right? I can't really give it to the fetus, not easily. So this is an injection we give to the mom. We give it, and then 24 hours later, we give it again, and it's going to help with the lung maturity for the baby. The nurse is educating a diabetic client to do kick counts or daily fetal movement counts. What's the benefit of teaching this? Good. Yep, it's a good indicator of fetal well-being. And that's an important thing when she's diabetic, that we're keeping track of how the baby's doing. The nurse is caring for 4 3-day postpartum clients. Which client assessment requires the need to follow up? Okay, good. So lochia that's red and has a foul-smelling odor. What's the concern there?
Infection.
Mm-hmm. So, and what infection could that be?
Endometritis.
Good, endometritis. So we're concerned that that could be endometritis. So other symptoms besides foul-smelling odor for endometritis is what?
Fever.
Fever. Maybe abdominal tenderness. Okay. Let's see what else is on here. A client with colostrum discharge from both breasts, that's normal. right, at 3 days postpartum, it might be transitioning to mature milk because that usually happens between day 3 and 5, but that's a normal finding. Client with mild after pains is a normal finding. Pulse rate of 60 is a normal finding. It's also, let's see, her lochia should be red right now. What should happen with her lochia usually after the day 3? Like even tomorrow, what might her lochia look like?
Pinkish.
Mm-hmm. Yep, that's serosa switching to pink and mucousy. Two hours post-delivery, the fundus is 3 centimeters above the umbilicus and to the right. What can bladder distension cause postpartum? Okay, so if the bladder's full, and so that's when we just talked about our M's, right? With our bleeding, massage the fundus, manage the bladder, and give medications, our uterotonics. If the bladder's full, it can cause the uterus not to contract well. And so if that happens, we can have a lot of hemorrhaging that happens, which is why managing the bladder is one of the things to do if she is bleeding. But for this patient that you went and you assessed her and her uterus is not, remember we, on one of the other game questions, we said we wanted to find it at the belly button. It's now 3 centimeters above the belly button and it's not midline. It's deviated. That, and typically with a full bladder, it goes to the right. It can go either way, but usually it goes to the right. So this patient has a full bladder. So if she has, if her uterus is boggy, we're going to massage it, right? And we're going to see what her bleeding's doing. I need to manage the bladder somehow. So if she's not bleeding, I might let her get up and void. If she is bleeding, then we might do a catheter. But somehow we need to empty the bladder so we don't have a hemorrhage. Okay. A pregnant client presents to the clinic with a complaint of a severe headache. What should the nurse do first? Good. Put a cuff on her. Assess the blood pressure first. So for the person who selected protein urea, yeah, it's a good idea to check that as well. But a lot of things could cause a severe headache. In order to know if this is a preeclampsia concern, a good way to know is to check her blood pressure. Okay, if I put a cuff on her and her blood pressure is 110/60, then I'm not as concerned that this is a preeclampsia thing. Something else is causing her headache. Okay, so assessing a blood pressure if we have signs. Also, I would do the same thing. Like we had a question earlier about a patient that had blurry vision. If I have any of those symptoms, you know, epigastric pain, any of these things that go, that could be preeclampsia, then let's check a blood pressure and see. Is she hypertensive? And we can go from there. A client's receiving magnesium sulfate for severe preeclampsia. What action should the nurse take? Okay. Calcium gluconates are antidote for toxicity. Okay. Yellow, increase the infusion rate if the client's urinary output's above 30. That's not indicated. Discontinue the infusion if the client's respiratory rate is below 16. We're
I
gonna
read the question wrong.
say you
My
probably
bad.
thought it said 6, right?
Yes, I read the question wrong.
To say we're not going to need to do that for a respiratory rate of 16, but if she has true respiratory depression, we could consider that for sure. Monitoring blood glucose level every 4 hours isn't indicated, but definitely having calcium gluconate on standby is important. in case she develops signs of toxicity. The best response to a woman who tells the nurse she feels tired and sick all the time since I had my baby 3 months ago. Yep. I'm concerned about how you're feeling. And this is a time when we could start asking some really open-ended questions, right? And try to get her to talk a little bit more about how she's feeling. But this is concerning. What might be happening with her?
Postpartum depression.
Postpartum depression. Okay. What signs might we see with postpartum depression?
Lack of wanting to do things that she used to enjoy, sleeping a lot,
Mhm.
not really wanting to engage with the baby.
Yeah. Yeah, good. So we could see signs of detachment. She might even have some thoughts of self-harm. If you're in my class in our discussion board, I had put a video from an influencer that was sitting in her car outside of, I think, a Target, crying, blowing her nose in a diaper, telling the world, how worthless she felt and how maybe they'd be better off without her. This isn't a patient that is necessarily impulsive and going to act on these feelings like your psychosis patient, but definitely just like any patient with depression, sometimes they just feel worthless enough that they might have some of those concerns. Okay. So definitely we'd want to talk to her and get more information and see if we need to get her some help. Rh negative women with threatened abortion should receive RhoGAM. True or false? Some true, some false. Okay. What's a threatened abortion? Does anybody know? With a threatened abortion, we still have a baby in the uterus. It still has a heartbeat. We're having bleeding, but maybe the cervix isn't opening. Okay. And we might want to try to keep her pregnant. If she's Rh negative, we'll give her RhoGAM because we don't know if the baby is Rh negative or Rh positive. And anytime that there's bleeding in pregnancy with an Rh negative mom, it's appropriate to give RhoGAM because of the possibility that the mother's blood could see the baby's blood. If it happens, it's going to trigger that immune response if it's Rh positive. So this mom should get RhoGAM. The other things with this mom too is that we're going to try to keep her pregnant to an age of viability. And so a threatened abortion is going to be before how many weeks gestation?
20.
Okay. And so if we can get her to an age of viability and maintain the pregnancy, then that would be great. So we'll give her RhoGAM. We might also have her limit her activities a bit. We used to do a lot of bed rest, and we can do kind of a modified bed rest if we need to, but long term, that's like not a long-term solution. But limiting activity, also limiting intercourse or anything in the vagina and things like that to try to maintain the pregnancy if we can. But then we'll also give her RhoGAM because of the bleeding. The nurse is caring for a client with an ectopic pregnancy. Which finding or findings does the nurse expect? Okay, so the answer to this was actually all of it. What's happening with an ectopic pregnancy?
It's in the fallopian tubes.
Yep. So the pregnancy's in the fallopian tube. What happens with bleeding is going to depend a little bit on where we're at on this process. So we're going to have a positive pregnancy test because it did implant. So the body does make HCG. As is growing in the fallopian tube, it can cause pelvic pain, especially if it ruptures. It can cause pelvic pain. If the tube ruptures, we can see vaginal bleeding. We can also have her bleeding into her belly, which can also cause a referred pain into her shoulder. So she might have shoulder pain on the affected side, pelvic pain, bleeding, vaginal bleeding, signs of hemorrhage. So what's our number one vital sign change with bleeding?
Tachycardia.
Tachycardia. If she loses a lot of volume, we can also maybe see hypotension and some of those things as well. So there's a lot of things that can go into this. All right. If a patient is diagnosed with an ectopic pregnancy and the tube is still intact, they can give her a medicine called methotrexate, which will stop the dividing of the cells and stop the baby from continuing to grow. And then the tube won't rupture. And so then we don't have all of the bleeding risk. But I had talked to a provider that had just that night gone down for an ectopic and came back up, and I asked, I'm like, out of curiosity, how much blood was in her belly? And he said definitely over 500 mLs. So that's a lot. So we can see signs of hemorrhage for sure. During a vaginal delivery, the fetal head is delivered and the shoulder does not follow. What's the first maneuver the nurse should assist with? Good. So we looked at this earlier. So the first thing to do is McRoberts. And how do we do McRoberts?
That's the
To the chest.
So we're going to flex the knees back, and so her thighs are on her abdomen to change the pelvis and try to lift the pubic bone to release the shoulder. So the first thing to do is McRoberts. So call for help, start doing McRoberts, and then be prepared to do suprapubic pressure or position change or whatever that they need. The nurse is assessing the client in the immediate postpartum period. Which of the following signs or symptoms would indicate the client is experiencing uterine atony? Okay, we're in the immediate postpartum period. Uterine atony is going to be characterized by boggy uterus. Okay. Decreased fundal height is not going to be a sign of uterine atony. Moderate lochia rubra is actually a normal finding in the immediate postpartum period. Board-like abdomen isn't going to be seen here. Where might we see a board-like abdomen that would be concerning?
That was the placenta previa
And
or
that's
the eruption. The
it's
eruption.
the
The placenta
abruption.
eruption.
Yeah, good. It's the abruption where we can see that rigid board-like abdomen. Yep, good. So this patient's postpartum, so we're not worried about anything placental with her. So the boggy uterus is going to be the sign of uterine atony there. I love that you were able to pull placental abruption out of that. That was great. And then the nurse is caring for a client receiving terbutaline to prevent preterm labor. Which maternal assessment finding would be relevant to consider prior to administration of the medication? Okay, so does anybody know the side effect of terbutaline?
I know that it brings everything up, like the flight or fight.
Yep, and then it causes tachycardia. So if our patient's heart rate's already 132 and it's going to cause it to go up, that would be a relevant thing to know. So I definitely want to know what her vital signs are before I give it. And if she's already tachycardic, I will have that conversation with the provider. Are you sure you want me to give this medication? Her heart rate's 132. Okay. I think that might be the last question. Well, considering Brandy started late, that's pretty impressive. Good job, guys. All right, so based on the conversations we've had today in the game, do you have anything else on your mind? Any questions about anything?
Are we able to play that game solo or no?
I don't, so I think that I can set it to be available to play for a short period of time. Let me look real quick. It's not readily available. I
Okay.
think you would have to sign up for that platform, the Blue Kit, which it's free. But I think that you have to sign up for it, and then I can schedule up to 14 days. So I can schedule it up to the 23rd. I don't want to assign a code. There. Let me try this. So let me copy this into the chat and somebody click it and see what happens. And if it works, then I'll send it out to everybody with my recording and it'll be posted. But somebody click this and see if it lets you get into it. I'm going to stop our recording if we're done talking about concepts though.